Welcome to A&A Investigates, a monthly podcast featuring the latest in neurology and neuroscience brought to you by the American Neurological Association. I'm your host, Adeline Goss. Many autoimmune neurologic conditions lack Food and Drug Administration-approved therapies and are treated instead with off-label immunomodulatory treatments like steroids, plasma exchange, or B-cell depleting therapies. But this landscape is beginning to change. In recent years, the FDA approved several new treatments specifically for neuromyelitis optica spectrum disorder, and there are other novel therapeutic targets that look promising in neurologic disease. Here today to describe this spectrum of immune-modulating therapy is Dr. Jeffrey Gelfand, neuroimmunologist and Associate Professor of Clinical Neurology at UCSF. He specializes in treating patients with rare neuroinflammatory conditions, and he'll talk to us about the new drugs for NMO spectrum disorder, as well as off-label use of immunomodulatory therapies for a range of other neurological diseases. Dr. Gelfand was interviewed by A&A producer Dr. Rohini Samudralwar. Here's Rohini.
Welcome, Dr. Gelfand. Thank you so much for joining us on A&A Investigates. We both share an interest in the rare neuroinflammatory disorders, so I am very excited to speak with you today.
Thanks so much for having me.
Well, 2019 was considered the year of NMO and brought us several FDA-approved treatments. Could you discuss some of the new therapies?
Certainly. As you said, 2019 was a very exciting year with not just one, but three licensed new therapies for this condition. And this is really the culmination of several years of research into both the mechanisms as well as how to conduct clinical trials in rare diseases. There are three new treatments. One is called eculizumab, which is a humanized monoclonal antibody that binds to complement. It targets the C5 component and prevents formation of this membrane attack complex. In other words, it's a terminal complement inhibitor. And aquaporin 4 IgG, which is involved in the pathogenesis of NMO, it's the NMO antibody. It's thought to trigger the complement cascade. And a randomized blinded trial showed that there was a substantially lower relapse rate compared to placebo in the eculizumab treated group. And of note, in this trial, placebo group patients were allowed to continue on other immunosuppression, and more than 3/4 did this. And the benefit that was observed was on top of that. The major risks include infection, and particularly because of the complement, we worry about meningococcal and encapsulated bacterial infections. And so for this reason, there's a vaccine requirement for meningococcal vaccination. The second treatment of note is called satralizumab, and this is an IL-6 inhibitor. Satralizumab is a humanized monoclonal antibody that targets IL-6, and it too reduces relapse rates in aquaporin 4 seropositive NMOSD. And this is supported by data from two randomized controlled trials. And major considerations for risk include infection and specifically cellulitis and airway infections, as well as infection generally. And then the third agent that came out in this series of three licensed therapies is called inebilizumab. And this is a humanized monoclonal antibody that targets CD19. And CD19 is a protein expressed on B cells as well as plasmablasts. Now, of note, CD20, which is what we think of in terms of B-cell depleting therapies such as rituximab, CD20 is expressed on B cells, but not on plasmablasts or on plasma cells, which make antibodies. And so CD19, by targeting this, has the potential to get one more step into this B-cell maturation pathway by getting plasmablasts and getting at some component of antibody production. So at least conceptually, that was one of the rationalizations for using a CD19 therapy for an antibody-mediated disease like NMOSD. And this therapy was also studied in a placebo-controlled randomized controlled trial, and the trial was actually stopped early due to efficacy, and the FDA licensed this product for use in aquaporin 4 seropositive NMOSD. And the risks are similar to what we think about with CD20 B-cell depleting therapies, and these include infusion reactions as well as infection, among other risks. And then cost with all of these new treatments is another major consideration.
Apart from these three new licensed therapies for NMO, there is a long list of autoimmune-mediated neurologic conditions that don't have FDA-approved therapies. And so I want to take a step back for a few minutes to review some of the medications used off-label to treat these conditions. Let's start with our therapies for the acute phase of autoimmune neurologic disease. How do these therapies work, and what are some of the major things we should consider when reaching for each of them?
Certainly. Number one would be glucocorticoids. And the general concept here is that glucocorticoids, steroids, target many, many aspects of the immune system. Some of the early effects include drops of IgG, as well as B cell and T cell function, but there's really many downstream effects on the immune system. And as any clinician who cares for patients on glucocorticoids needs to address in terms of adverse events, there are also many other systemic effects and organ-specific effects that we all need to pay attention to try to mitigate risk and understand the pharmacological consequences. But because of their rapidity and because of just how well they work for many conditions, glucocorticoids remain a mainstay for treatment of many neuroimmunologic conditions. Other considerations include intravenous immunoglobulin and more recently subcutaneous delivery of immunoglobulin. In terms of how it works, there are several theories. One would be that the antibodies themselves can actually target other pathogenic antibodies. There may also be a bit of a flooding the system effect, where by having an increase in circulating IgG, there's less production or greater clearance of IgG as well. The concerns with IVIG include one being just availability. There's been a shortage nationally. There's also both the infusion risk as well as the viscosity aspect, so there can be a risk of thrombosis. Plasma exchange refers to the removal of plasma to filter the pathologic components in the blood and then to replace that volume with another substance. And plasma exchange removes pathologic antibodies as well as other antibodies that are sort of bystanders in this process, but it also removes other immunologic substances such as immune complexes, and it can also remove certain small molecules, medications as well. So it's important to consider the effect of plasma exchange, not just on immunology, but also on prior or current therapies as well. The major risks with plasma exchange are that you have to have access. So either expert central line placement, or some centers can use more peripheral access. But because of the line risk and because of the filtering risk, there can be risk of infection, as well as risks related to hypotension, as well as coagulopathy. There's also the access issue that many healthcare systems can only deliver plasma exchange currently in the inpatient setting, requiring several-day hospitalizations. And not all health systems can provide outpatient plasma exchange as an option.
So that reviews steroids, IVIG, and plasmapheresis, things that many times we use during active symptoms. But what about some of the long-term treatments that we consider, things like TNF-alpha inhibitors or other oral options in the immunological world?
Absolutely. So there are several other broader spectrum immunosuppressive therapy options, as well as more targeted therapy options. And so in terms of oral broader spectrum therapies, there are several that we commonly consider. One would be methotrexate. Methotrexate's an analog of folic acid, and it interferes with dihydrofolic acid reductase activity, therefore affecting purine and pyrimidine synthesis. Essentially, it targets fast-dividing cells, including lymphocytes, so it works by decreasing lymphocyte and immune function. Other therapies within the sort of general immunosuppressant category include azathioprine. Azathioprine is an antimetabolite, and it is a purine analog and also interferes with DNA and ribonucleotide production. And this leads to less circulating B and T lymphocytes and reduced antibody production. Another medication within this broader spectrum category to consider would be mycophenolate mofetil, MMF, and this suppresses B and T lymphocyte proliferation and antibody production by interfering with purine metabolism. In terms of targeted therapies, there are several to highlight. One would be CD20 therapy. This is B-cell depleting therapy, such as rituximab, and then more recently, ocrelizumab and ofatumumab, as well as several others coming down the pipeline. These agents are antibodies, monoclonal antibodies that target CD20 on B cells. And B cells express CD20, but plasmablasts and plasma cells, which make antibodies, don't. And so one common misconception about these medications is that they are targeting antibodies or dropping antibodies, but that's not what they're doing based on the mechanism of action. They are targeting B cells, which also interact with T cells. And it's this more complex immunologic interaction that likely explains their benefit in many neuroimmunologic diseases. Other therapies to highlight include TNF alpha inhibitors. These are monoclonal antibodies that target TNF alpha or its receptor. Early data in multiple sclerosis from animal models suggested that this would be a potentially beneficial strategy to treat experimental autoimmune encephalitis, EAE. But in real-world clinical trials in the 1990s, this had to be stopped early due to harm because TNF alpha inhibition made human MS worse. And this is one of the contraindications, MS or known MS, to using TNF alpha inhibiting therapy. Now, for other autoimmune diseases, including several neuroimmunologic conditions, there can also be a benefit for TNF alpha inhibition, including for neurosarcoidosis, as well as for conditions like neuro-Behcets, as well as potentially other conditions as well. There's also the question about cyclophosphamide. Cyclophosphamide is an alkylating agent that interferes with DNA, and it causes death of rapidly dividing cells, including immune cells like lymphocytes. This is sort of an old standby or an old tried and true therapy for broad spectrum immune suppression for neuroimmunologic conditions, particularly when the condition is severe or we're unclear about what to target mechanistically, or as a first-line treatment strategy after glucocorticoids for conditions like CNS vasculitis. There are several other nuances with these agents, and I would encourage clinicians to seek out expert colleague guidance and pharmacist guidance as indicated with any questions about this, and for protocols for safety monitoring, which is an important part of prescribing these medications.
So what are some of the novel therapeutic targets that may be useful down the line for some of the conditions you mentioned or others such as autoimmune encephalitis?
There's several exciting potential therapeutic targets. So I can highlight a few, but this is by no means an exhaustive list. And this is a very, very active area in the field and also in drug development generally. One area would be the expanding role of anti-IL-6 therapies. We discussed earlier on in the podcast the role of satralizumab for NMOSD, but IL-6 is involved in several other aspects of immunology and disease. And so there could be a potential role that way, as highlighted by another version of the medication called tocilizumab, where there's data for refractory autoimmune encephalitis, as well as potentially for other autoimmune neurologic conditions. Other immune targets include trying to get at antibody production itself. So we talked earlier about how CD20 targets B cells, but not more mature plasmablasts and plasma cells, and how even CD19 therapies get at plasma blasts, but not at plasma cells. So there can also be opportunities to target antibody production itself, including potentially CD38 therapy, such as has been advanced for treatment of multiple myeloma. There's also exciting data about neonatal FC receptor antibodies that can help increase clearance of IgG as a rapid way to drop circulating IgG, which may be a way to target pathologic antibodies as a more targeted approach than others such as plasma exchange or IVIG generally. And there's several studies that have been presented at conferences and in abstract form and starting to be in papers showing benefit of this approach for neuromuscular related antibody mediated conditions. There's also data with proteasome inhibitors that was published for autoimmune encephalitis with NMDA encephalitis, such as with bortezomib, but it's still unclear in terms of the benefit relative to tolerability and sort of the kinetics of how much greater benefit there is to that over conventional therapy. And increasingly in the multiple sclerosis world, there's also therapies that are targeting microglia. And the question will be whether that has any greater benefit for diseases like multiple sclerosis or other neuroinflammatory diseases once those treatments are further studied.
That was great, Dr. Gelfand. Just a final question before we wrap up. We've spoken a lot about immunosuppression today, but there are other ways to modulate the immune system to our benefit. Can you discuss some of the newer options that we may have available to us in this category?
Yes, this is also an exciting time in immunology generally, and neurologists benefit from understanding how the immune system can be suppressed, but also how it can be augmented. And perhaps the best example of that has been with this explosion of checkpoint inhibitors to treat cancer. What we see is that while they can help patients with these tumors, a subset will have neurologic immune-related adverse events. And these are in the literature are called IRAEs. And the incidence of neurologic related adverse events with these increases in immune function to treat cancer are estimated to be about 1 to 12% of patients. And so this is an example where we can also see consequences of these pro-inflammatory treatments as triggers of neuroinflammatory conditions. At the same time, these therapies that increase immune function can also potentially be harnessed to treat neurologic disease, such as some of the exciting emerging data with these therapies, such as pembrolizumab, for infections such as PML, progressive multifocal leukoencephalopathy with the JC virus, which occurs in people that are immunosuppressed. And so this might potentially provide a way to augment immune function. And so I think this is going to be a very exciting time in neurology going forward to try to harness the immune system therapeutically, both in terms of the suppression standpoint, like we have been trying to do in a more and more targeted and elegant way to treat patients with inflammatory neurologic and autoimmune diseases, as well as to augment immune function in patients such as those with primary malignancies or those who have a need for it, such as those potentially with infections. And so I think this will be a very, very exciting time in the field going forward.
Wonderful. Thank you. This was such a comprehensive discussion on the wide spectrum of therapies and specific targets that are available. Dr. Gelfand, we really appreciate you speaking with us today.
Thanks so much for having me. It's a real honor to be here.
That was Dr. Jeffrey Gelfand, neuroimmunologist and Associate Professor of Clinical Neurology at UCSF, interviewed by ANA producer Dr. Rohini Samudralwar. That's it for today's show. If you'd like to hear more episodes of ANA Investigates or pitch us an idea for a future podcast, you can visit our website at myana.org and click on the Education tab. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host and the executive producer of the show. Episode producers are members of the ANA Education Innovation Subcommittee, chaired by Drs. Megan Ritchie and Romer Giacaden. This is your logistics coordinator, Jen Hurley. Copyright, the American Neurological Association.